Welcome everybody who's coming in. You're a little early, but we're delighted that you're here. And I'm Irene Higginson, and I'm a professor of palliative care and policy. I'll introduce myself properly in a minute, and I'm chairing this webinar. But we've got a fantastic program. We'll be starting fairly promptly in about a minute or so's time. So thank you for getting here promptly. And we'd love you to just introduce yourselves in the chat. And be aware that this is being recorded, so the recording will be available, and also that there's a Q&A function where you can post questions. So please do introduce yourselves in the chat if you'd like to. It's great for speakers to know who's here. And you're very welcome at this moment to turn your cameras on. Sometimes when the presentations are running, people do turn off just to save the bandwidth and so on. So welcome, Helen Smith. Great that you've started us off introducing in the chat, and we look forward to hearing others. Hi, welcome, Rosemary. Hi, Emily. Welcome, welcome. Great, so people are coming in and we're pretty much on time to get going. Welcome, Scott. And so, Mev, I wonder if we could start by just sharing the opening slides. So I'm delighted to welcome you to this webinar about developing inclusive practices around consent and mental capacity in palliative care research. And we have a lineup of 3 excellent speakers who are going to speak to this topic. Caroline Barry is going to, I think, convene all the speakers, and she's going to discuss the NHS England Research Engagement Network and inclusive practices and so on. And then she will be handing over to Kathy, who's research lead at NHS England, and is going to talk about the issues about improving diversity in research. And also we're going to hear from Vicky Shepherd from Cardiff University, who will be exploring some of the ethical, legal and practical challenges there. 3 very experienced speakers in this, and I'm really looking forward to hearing from them. Just to say a little bit before we get going about the ARC, it is running until March 2026. And the co-national leadership is between ourselves, South London Applied Research Collaborative, and the East of England Collaborative. And Mev, who's here on the call, is really supporting these national activities. And you can see our aims and objectives there, and we're very keen to engage and work with other ARCs. Is there a final slide on this? Mev, it's not now, is it? We've finished those. Thank you. So I'll let you stop sharing. And in that case, I think we're ready to go. I just flag to people, as Caroline's going to start and introduce herself a little bit more, to please, those who've just joined, welcome to this ARC. I'm Irene Higginson, Professor of Palliative Care. I'm chairing this session. Please do put questions in the Q&A slot as the session goes along if you have questions, and we'll try and make sure that we get to them at the end. But now, delighted to hand over to Caroline Barry, who's going to take us through this session. Thank you.
Thank you, Irene, and thank you to ARC for having us here today and supporting us to discuss more about this work. I apologise in advance, I've got COVID. I'm hoping my voice is going to sort of last till the end, but unfortunately I'm ably supported by 2 colleagues who will be doing a lot of the talking this morning as well. So thank you. As I said, really this is about an ongoing project, and I should say there will be an opportunity at the end to register your interest in joining a national group that we've put together to do more work in this area. So even if you're watching this back having not got to it today, or perhaps don't get a chance to ask your questions, there are other opportunities for ongoing involvement I'd encourage you to make the most of. So as Irene says, really what we're talking about today is ways of making our palliative care research more inclusive for people who might have challenges in communication or cognition when their ability to provide that informed consent to research is impaired. And the specific parts of this work that related to palliative care are funded by NHS England as part of their Research Engagement Network programme, which has got the overall aim of basically improving the diversity of research participation. So I thought it would be really apt to start our discussion this morning with some words from Kathy, who, as Irene's already introduced, who's going to run through some of the high-level challenges around diversity in research more broadly, and importantly, some of the national priority actions that are being taken to improve inclusivity. So we're going to hear from Kathy first, then we'll go on to hear from me for about 15 minutes to talk about some of the work we've been doing in palliative care, specifically to understand some of the specific structural challenges and barriers that people might face accessing research, particularly when they've got those cognition and communication challenges. And finally, I'm going to hand over to Dr. Vicky Shepherd, who's drawn upon her background in critical care to develop a really significant body of work addressing some of the challenges that we see when we try and negotiate alternative models of consent, and how some solutions have been identified in different disciplines and across the research cycle. And then we're going to have a good 15 minutes at the end for you to give us your questions and have a bit of a discussion. But firstly, now I'd just like to hand over to Kathy.
Thank you very much, Caroline. So good morning, everybody. I'm glad to be here today. I'll be talking about the importance of inclusion in research, not specific to the setting that you work in, though I've tried to draw in a few bits and pieces. So hello, yeah, my name is Kathy Jays-Ward. I'm research lead in the embedding research team at NHS England. So while the team are predominantly researchers by background, actually our role is not to do research, but rather to help the NHS become a better place for research to take place. So we do this through a number of work streams. Some are about increasing the scale of research or the pace of research. The work I lead is around increasing the diversity of research and also providing system guidance and assurance. Next slide, please. There we go. So why is research inclusion so important? I mean, there is, to my mind, a moral obligation to make sure that the research that one is doing applies to the people that it will affect downstream. But there is plenty of anecdotal evidence. There is an increasing body of published evidence of why it is so important that we focus on research inclusion and work hard to make sure that that is an important factor in the research that you're doing. So we know that health differences across ethnicity may reflect different disease pathologies and responses to treatments. There are genuine physiological reasons. There are also cultural and behavioural reasons that all the treatments, the medicines, the interventions that we produce may not apply equally well to everybody. We do not want to inadvertently be increasing health inequalities and outcomes, experiences, and so on, access as well. We know that there's differences in effective doses of treatments. We know that there are, as I mentioned, cultural and behavioural reasons why services may not suit everybody. People's experiences can differ. We know things like the quite significantly reduced life expectancy of people with severe learning difficulties, for instance. There's no physiological basis a lot of the time for that. There are other reasons. But the implications are that the national evidence-based guidelines may confer greater benefits to particular communities, particularly those who have helped shape the underpinning research. The little numbers I have up the side here, these are not numbers to celebrate. It's exactly the opposite of that, actually. So 56 is the number of people that took part in palliative care studies, according to the NIHR. Last year there were 2 open to recruit studies, 56 recruits. 28 and a chunk thousand people, that's in dementia and neurodegeneration. So that number is not unrespectable. 486 is how many people took part in social care studies last year. When you put that in the context of there are over 1 million people participating in research last year, those are not very high numbers. And I think particularly at 56 that relates to palliative care really does show how very difficult it is to bring people into research in the setting that you all work in. Next slide, please. So from that slide, I would like to give the message that research inclusion is something that is taken increasingly seriously at national level. So some of you may be familiar with something called the RRG, the Research Reset Resilience and Growth Group. That was convened during COVID. You'll all be aware that there was a lot of disruption to the research sector, a lot of reprioritisation of activity, as there absolutely should have been during that time. And the RRG group, which has now been renamed as the UK Clinical Research Delivery Group, UKCRD, during the summer this year, we got permission from that group, which is a national group covering, it's led by the Department of Health and Social Care, but it involves all those sort of major stakeholders in the research sector in this country. We got permission from that group to go ahead with some activity specifically around research inclusion. We formed a research inclusion group, and we are now working with that group to map the major infrastructure and interventions that are taking place in this country around research inclusion. And we are then going to be working towards a roadmap to improve, hopefully, how that is looking. So we have so far broken that down into 7 domains of activity that we would like to target research inclusivity action to. That's requirements and expectations, trial participation and access, workforce diversity itself, data, community engagement, public awareness, and also sharing of best practice and learning. And I particularly wanted to flag that under number 1, requirements and expectations, there is already a statement of intent flagged in there around including older people in research. I imagine quite a few of you may be aware of this, may have even been signatory organisations in this during the summer, but I have included there a quote from Professor Chris Whitty about the need for older adults to be included in research. I'm not suggesting that all older adults lack capacity to consent, or indeed that palliative and end of life refers only to older people, but I think just as a broad overlap, this is a useful statement of intent to flag today. Next slide, please. So how do we go about changing research inclusion? How do we improve research inclusion? So a couple of years ago, we did a piece of work that was really sort of exploring what barriers to research inclusion there are out there. NIHR have done similar pieces. Maybe some of you individually in the group have also done similar pieces. There are hundreds of barriers to research inclusion, to stopping research from having representative populations included in it. We broadly categorised it down to language barriers, accessibility and mistrust. Other people may have categorised it slightly differently, but realistically the messages are the same, that these are broad categories of things that are very difficult for an individual researcher to address. So we set about at NHS England to address what we thought as a system level was probably the hardest one of these, which was mistrust. So next slide, please. And from the will to tackle this mistrust issue was born the Research Engagement Network programme. So I lead this nationally with my colleague who's an engagement professional and researcher by background. The programme now is funded by both NHS England and the Department of Health and Social Care. The aim of the programme is to increase diversity in research participation. We do that by giving funding to teams on the ground who engage with underserved communities around research. So each of the teams that we fund includes an NHS partner, an NIHR partner, and crucially, it includes the communities on the ground, the groups representing communities that we are very conscious are underserved by research. So we recognise that the expertise, not just of the researcher, but of also the communities themselves who are engagement specialists, are what really drives this research. So we set a broad direction of travel for the programme, some different objectives every year. They just sort of iterate every year, and then we let them determine on the ground how they will address this. So next slide, please. So I'm not going to linger on all the numbers on the next slide, other than to say that we had 47 teams active in 24-25. We report on an annual basis, rather like the ARCs do. So yeah, 47 teams last year across most of the country. If anyone is here from Frimley today, I haven't seen anyone in the chat. I'm very sorry you were not involved last year, but we are hoping to bring them in again this year. 250 odd community champions involved in this piece of work. Last year alone, 29,000 people from underserved communities engaged across 700 odd public facing events. And in a lot of these cases, a lot of people don't engage with health services routinely at all. So we've had access to a lot of communities through this partnership approach that maybe lots of other people in their research have not done yet. We are all about the sharing of the access though. Next slide, please. So that is our sort of broad REN activity, but we did start off an additional cohort of REN activity about 2.5, 3 years ago now. We funded a number of projects. These are the 3 that we've funded all the way through so far. So one of those was about addressing access to clinical trials by addressing the patient information leaflets, which are habitually very, very complex. So they've recently finished their piece of work to develop an accessible patient information leaflet. We'll hopefully see more of that across the country soon. We have a team that are looking at reducing the age of inclusion in cancer trials from 18 to 16. That's having a knock-on effect on other clinical settings as well, not just cancer. So that piece of work is going beautifully. But today, absolutely delighted to hear a bit more from Caroline about No Choice, No Voice. So this was about reducing system factors that are barriers to including impaired capacity people in research. So I will hand back to Caroline there. And also just to flag that when we were assessing the bids that we had for this round of funding, this is the project that routinely kept coming up as it was the clear favourite by all of our lay panel members. It just spoke so clearly to people's experience of life. So I will pass on to Caroline. Thank you.
Thank you, Kathy. And it's been an absolute pleasure working with Kathy's team on this as well. And one of the things that possibly we haven't spoken about is the extent to which the REN teams have collaborated with each other and shared the learning. And I've learned so much about really diverse settings and people who come from very different life experiences. And actually that shared learning has, I think, possibly been a bit of an unexpected benefit of this programme as well, aside from the own work that we've been doing. But as Kathy very correctly says, I'm very for highlighting as well, these are very much partnership programmes. I work with a number of voluntary sector organisations on this piece of work, including the Motor Neurone Disease Association, the Anne Robson Trust, and also sort of local care homes and local volunteers. So I'm really here presenting on behalf of that very large team of people who are involved in this bit of work. So as we said, this was only about 18 months ago that we started this work understanding some of the structural barriers to research participation for people with impaired capacity to consent to research towards the end of life. But before I launch into the project, I thought it might be helpful just to briefly set the scene about how I came into this. So my background is as a palliative care consultant. I work up in Norfolk. But really, for as long as I've worked in medicine, I've been really interested in that dynamic about how we make decisions towards the end of life when someone's not able to speak for themselves. So one of my first jobs was in stroke care in Addenbrooke's in Cambridge, and I remember we used to get these prominent academics or professors come in after a catastrophic stroke, and there'd be so much wrangling at the bedside trying to decide what the right course of action was for these people's care. And sadly, often I had a sense that the outcomes that resulted from these conversations often perhaps wouldn't have been what that person would have valued for themselves. And so I took the potentially slightly unusual step then of studying for a degree in medical law, a master's in medical law rather, specifically looking at the application of the Mental Capacity Act towards the end of life, with a view to getting a bit more insight onto this decision making. I wrote my dissertation in 2013, 2014, which in retrospect was an absolute vintage year for the Mental Capacity Act in the courts. So we had the Supreme Court, Lady Hale, talking about best interests, and actually is it what the doctor should say it is, or should it be something a bit more holistic? That was the David James case. And then we had Cheshire West talking about deprivation of liberty. What is the right to liberty? And the famous quote, "A guilty cage is still a cage," and that court judgment had really incredible ramifications for palliative care, specific hospices. Those of you who were working at the time, I don't need to tell you the impact that had. And then on those not specifically mental capacity, we also had the Janet Tracy case versus Addenbrooke's Hospital around do not resuscitate forms and the duty to consult. So although it wasn't great for my mental health, I had to rewrite my dissertation 3 times in that period. I came out of that experiencing absolutely enthused about the impact of the law on our practice, and I was sort of thinking, okay, what next? I want to do some empirical research really to understand more about this process. And sadly, what I found was a bit of a black hole. So I appreciate I work in Norfolk, but at the time I felt that it was very difficult to identify any sort of supervisory support. There wasn't an obvious funding route to support this sort of research, and in terms of methodological approaches, the gap between the law and mental capacity in clinical research at end-of-life care, again, it felt a very difficult hurdle to overcome. So I took the decision to step back from research and threw myself into NHS consultant life and leadership. So over a decade later, to be able to have the opportunity to sort of understand a little bit more about why I faced the challenges that I faced, thinking about clinical research in this area, and also to see whether actually the situation had changed and whether it was still possible to do this work was a really welcome opportunity. And the first step that I had to take really was to understand, okay, to what extent were those challenges that I feel exist around inclusion of people with impaired capacity in research towards the end of life, to what extent was that representative of the national picture? So the first stage of the REM project was really about thinking, okay, what proportion of palliative care studies that we do currently include people with impaired capacity? So I've got the answer to this question because I did the work, but you don't. So I wondered perhaps if we could test the chat function. You can have a guess what percentage of NIHR portfolio studies, which I appreciate it's not all palliative care studies, but include people with impaired capacity consent. See if anyone's going to be brave enough to put something in. Oh, we've got some very pessimistic, very low, 0.55%. Alright, teaching, she's had this talk before. 10%. Okay, 20%. So answer, not many, as predicted. So we looked at about 2,000 studies, and we, palliative care is a specialty, is a new one in their portfolio. So as a standalone specialty. So we also looked at ageing, care home, dementia, hospice, palliative care. And what you can see, sorry, it's quite small, but blue is the people that exclude capacity. And in ageing, care home and dementia, actually, it wasn't. It was fairly proportionate in terms of about a third of the studies did include people with impaired capacity. And I should pause to emphasise that perhaps in comparison to some other areas of research, we're clearly not aiming for universal inclusion here. The key question we have to ask ourselves is whether the research question can be answered without the inclusion of people with impaired capacity. So clearly that's not going to be all studies. But we found that the dementia care home setting that they did potentially have studies that were more inclusive. However, when we look at palliative care, where the blue line is the studies where people with impaired capacity are excluded, you can see that it's the vast majority of palliative care and hospice studies don't have this kind of arguably more inclusive approach. And even when we dig deep into the ageing, care home and dementia, although on paper it's a more inclusive approach, actually those studies themselves, there were very, very few studies in that population that were actually relevant to palliative end of life care. So they did include people with impaired capacity, but it was about fluid hydration in care homes or flu vaccines. It wasn't about studies that are relevant to palliative end of life care. But the headline was that only 1 in 20 palliative care studies had an inclusion criteria that allowed for people who couldn't consent for themselves. So then the next question is, okay, so why aren't we asking these research questions that need to include people with impaired capacity, given that, particularly in the dying phase, we know, don't we, the vast majority of people will lose capacity towards the end of life. So given it's so relevant to people's experience of dying, why aren't we asking the research questions that require their inclusion? And that obviously involved thinking about the particular challenges that clinicians and academics face in this area. So we did a brief survey and amongst other things that showed that whilst clinicians in particular are very confident applying the clinical, if you like, the clinical, the medical, the health and care treatment decisions around the Mental Capacity Act in clinical practice, when it gets to the research provisions of the Mental Capacity Act or other legislation such as clinical trial regulations, their understanding is a lot more of a grey area. There's a lot less understanding, a lot less support to understand actually how this works in practice. But obviously surveys only give you a bit of the information, so really keen to get out and have some conversations with people involved in this work. We used a fairly sort of relaxed approach to discussing with people, sort of snowballing, just finding interesting papers that people have published, and then asking them, who else they thought we ought to talk to. So we spoke to nearly 50 people, And we also spoke to researchers, we also spoke to funders, we spoke to research ethic committees, charities and policymakers. And I think it was at this point over last winter where I'd had so many of these conversations that the experience just felt really sobering. We heard about the real challenges that everyone seemed to face navigating the approval procedures. We heard about really significant gaps in policy and information, about really specific procedural issues. So people want to do this right. They feel very worried about not doing this right with what might be perceived as a vulnerable population. But we felt that there were specific areas such as the use of consultees, where people felt that there wasn't the information and support guidance that they needed to make the kind of right decisions. We also heard from researchers who felt that, try not to be too controversial here, that in palliative care we've perhaps got used to, I think the quote was, over harvesting the low-hanging fruit, so doing perhaps the easier work, the easier questions to get the research done, rather than taking the time or perhaps having the funding to put the time into developing the kind of correct methodologies or the most appropriate methodologies to actually do work that's more inclusive. And perhaps most worryingly, we heard from people who'd produced some of the most sort of thoughtful, impactful and ethical research. And, you know, you read the paper, thought, wow, yeah, this is brilliant, it's how we should be doing things. And they say, do you know what, if I had my time again, I wouldn't do it. And when I get approached by people who want to do a PhD, I tell them, you know, don't do that. There isn't you know, you won't get your project done in time, it won't be approved. To sort of pick sort of easier things. So that was pretty sad, really. But it wasn't all bad news. We did hear about the really significant contribution that can be made when research relationships are prioritised, not just on an individual level, but also collaboration with funders who are willing to support with the time and the funding needed to develop that kind of methodologically sound research that this is more inclusive. But as Kathy alluded to, a big part of this work is about how we understand what the right approach is for involving people with lived experience of death, dying, and bereavement into the conversation. And when we think about people with cognitive and communication challenges, that, you know, becomes even more important to think about perhaps what the right participatory approach might be in this sort of circumstance. So we took a number of different approaches to try and understand this, including surveys and workshops in care homes and hospices, and the partnerships, as I've already mentioned, with the Anne Robson Trust, who provide butterfly end-of-life companionship volunteers in hospital and other settings, and also the Motor Neurone Disease Association, and the NIHR Enrich teams who support care home research. So working with the Anne Robson Trust, we did just a short survey with their people who work with them on their mailing list, if you like, so predominantly people who are bereaved, but also people living with terminal illness, just to get a sort of temperature check on how they perceived palliative care research, or how they felt about research in the last weeks of life. So see, it was kind of fairly quite a significant proportion of people affected by terminal illness themselves, but also bereaved family members. And the results were really interesting. They were almost like dead evenly mixed between a third of people who were really broadly supportive of research and felt that everyone had the right to participation, would hate the thought of being overlooked. A third of people were kind of a bit neutral, so didn't really perhaps quite see the importance, but no real objections. And then a third of people felt very strongly against being offered research or being involved in research towards the end of life. My favourite quote is this one: everyone is different, have their own views on this, tread carefully. But what we did find was that it seemed like the people themselves, the people who were affected by terminal illness, were more supportive. They were saying, well, no, I'd like to be asked. I wouldn't want you to not ask me just because, you know, you wouldn't want you to not bother with me just because I've got a terminal illness. But actually it was the relatives and carers who were saying, well, I already have so much to deal with. The idea of having to deal with research on top of everything else would seem like too much at this point in time. And that was interesting, really, because it took me back full circle to the stroke ward where we're with relatives and trying to decide what the right thing is for the person versus the person themselves, who may or may not be able to say what they want for themselves. So really, for the last part of the project, which was in 2 stages, when we were thinking about how we might develop recommendations to improve participation, I was very keen to think about what we call proxies, because there's lots of different terms that you might use to describe third-party involvement in research. But, you know, there's carers, family members, in some cases maybe volunteers or advocates, and what roles they might play in supporting people to involve, specifically thinking about things like advanced research planning, supported decision making and advanced consent, so that, you know, we think about that autonomy of the person, how that might be preserved as they advance in their illness and altered cognition, but their wishes about research might still need to be followed. So we undertook, it's not published yet, hopefully it will be shortly, but we undertook a scoping review of how proxies can be supported in palliative care research. And we developed some themes from that around things that might help support proxies to involve people with impaired capacity in research. A lot of this is probably quite self-evident, but I think those of us who've recently been involved in the Chelsea trial probably recognise some of these factors as well, around communicating the value, people understanding the point about why they're being asked to participate at this point in time, being responsive to the carers' needs around the right time to talk about research in the context of the care they're receiving, ensuring the right people are involved in terms of trust and connection, understanding that this isn't about making things any more difficult than they need to be. To understand the power situation, that actually an approach for research at a time where you're feeling at a very low ebb needs to be understood as absolutely the right to say no, but also that it's a privilege as a researcher to be allowed into these people's spaces at this time in life and being responsive and respectful of that. But also importantly that our uncertainty about the navigating the legal and the ethical context can cause to, you know, added upset and distress, and actually being clear about how we support people through that. So I won't go through this in detail because we haven't got the time sadly, but just to say that we did develop a theory of change based pulling on all the information that we'd gathered from the activities that we'd undertaken, and then we've developed a couple of core recommendations to follow on from this to try and address these structural barriers, and the two on the left, so around the research relationships and kind of contextual peer-based support, are two clear factors that we want to develop further. We had developed some of these things to address that, such as working with the Motor Neuron Disease Association to do some specific web-based tools for their researchers. So 50% of people with MND will have some form of cognitive and behavioural change, often it's quite subtle. So we've developed some learning support around that. We've developed some nice kind of visual aids to research awareness, both for researchers on the left and people living in care themselves on the right. We've developed some guidance for research ethic committees around involving people with impaired capacity in research and things they need to be aware of. And finally, last month we held a really enjoyable workshop in London where we convened a group of people with an interest in this area to think about what we might be doing in terms of next steps, which is going to look like some more written material in terms of how-to guides for researchers, and also looking about what more we can do with routinely collected data in this area. And as I say, at the end there's a QR code if you'd like to be further involved with any of the project, then you can register your interest there and I'll be in touch. But my voice is just about held out. I'm pleased now to be handing over to Vicky, who really is just a leading expert in this area. It's been a pleasure to work with. She's going to talk about some of the innovative methodological solutions that she's developed in other areas of research and how we might think about applying them to our palliative care population. Thanks, Vicky.
Lovely, thanks, Caroline, and glad your voice has made it this far. So I'm Vicky Shepherd, and similarly to Caroline, I guess I came into this whole kind of area of research through my clinical practice as a critical care nurse, and seeing again those kind of questions arising about how care and treatment decisions are made with and on behalf of people that might not be able to contribute their own views. And then as I stepped into a research role, I'm now based in a clinical trials unit at Cardiff University, I saw exactly those same kind of questions, but a complete absence of any kind of case law, I guess, to guide decisions. And when we think about research and clinical care, of course, they have these different purposes. So it became even more challenging. And that led to this programme of work I've been leading for the last 10 years or so in this kind of area. So kind of going to share some of those today. And they apply across populations that might have impaired capacity to consent more generally, but of course that includes people receiving palliative care, and there will be specific kind of implementations for that I'll draw on as we go through. So next slide, please, Caroline. So first of all, thinking about how some of these challenges that we've already heard a little bit about kind of span the whole research system, if you like. So there are things around the complexity of the legal framework. So when we think about the clinical trial regulations and mental capacity legislation and how those intersect, we've already heard a little bit about the challenges of the ethical review processes and how that might be viewed by researchers going through the process. And also about that kind of paternalistic protection that we've heard a little bit about as well. So people's views that actually burdening people with research might be something that they would wish to protect people from through their perception of that. But also some of the structural barriers, the resource requirements. Of course, it takes much longer and greater skills to recruit people that might have impaired capacity consent. The whole research infrastructure has not been designed for this population. The kind of metrics that research teams work to and the processes around that are all designed for people that can give their own consent to take part and might not necessarily fit the populations that we work with. And a general kind of lack of support and information for those involved. And then some of the methodological challenges as well. We might often see the restrictive eligibility criteria. We've heard a bit from Caroline about what that looked like from a portfolio perspective, and the kind of challenges of designing these alternative consent pathways when the person themselves can't give their own consent. So you can see how some of these kind of challenges span all those kind of areas. Next slide, please, Karen. But within a specific research study as well, we see the challenges at different times. And this work was drawn from interviews I did with researchers and others who spoke very much about how actually it can be difficult when you're designing a trial to know what particular arrangements to put in place. Again, when you navigate ethical approval for your study, actually when you're approaching potential participants and obviously need to support them to understand the information that they're receiving about a study and make a decision, or for those that we think might have challenges around capacity, assessing capacity and how we know how to do that, what skills and resources we draw on. When we then need to involve an alternative decision maker, that proxy that we've already heard a bit about, and how challenging that can be, finding the right person, supporting them to make decisions, and then of course revisiting consent and consulting others, because it's not this kind of one-off process, it's ongoing throughout a study. Next slide, please. And as part of that same study, I explored with researchers and others what kind of ethical, legal and practical challenges they encountered. And that first quote is something that resonates with a lot of people, and that is around how complex this area is. So you can see this researcher described this insurmountable black box of horrendousness that they dare not go near. It feels that if they do something wrong, they'll be illegal and the ethics police will come for them. And so you can really see why researchers steer away from involving people that might have impaired capacity consent from research, because why would you do something that you're worried about being illegal or not? They also spoke about the kind of lack of support and resources, this kind of potluck Googling, that even when they thought they'd interpreted the legal and ethical frameworks requirements, when they went to a research ethics committee meeting, actually it turned out they'd interpreted them wrong and it was a really negative experience. And then they also spoke about the need for more support and guidance, thinking about the terminology, who's the right person to approach to give consent on someone's behalf or to consult, how that might differ between different countries of the UK and beyond. And all of that might help people have more confidence when designing this type of study. Next slide, please. And that's what's led on to kind of a series of resources and tools that we've developed to help bring that kind of confidence. And the first one is thinking about the knowledge gap. So actually knowing what the legal frameworks are that you'll be working within, what the ethical requirements are, particularly when you're applying for ethical approval, and the kind of methodological issues that you need to consider and work through. So last year we co-designed with stakeholders some e-learning on this. You can see it's kind of modular in format, so you can dip in and dip out. It covers the legal frameworks across the UK, and I say touches on the kind of ethical requirements. There's a downloadable how-to top tips kind of guide to help you apply for ethics approval, and then the methodological questions as well. As you can see on the right hand side, it's free to access. You can download a certificate of completion for your kind of CPD portfolio if you like, and there's a survey at the end, so if you have any feedback for us, please do consider completing that. Next slide. And then as part of that, we obviously need to design in inclusivity into our research. It's really difficult to design a study and then later on try to bolt on aspects of inclusivity. So designing that from the outset. So adapting some work from the NIHR, who had developed an include framework, we adapted that work for this population. So this gives a structured tool for researchers when designing a research study to help them reflect on and then build in inclusivity components. So you can see in the middle, it asks you a series of questions to reflect on. There are worksheets you can complete, so you can actually record your kind of decisions and thoughts and actions. And importantly, you can also build in what you think in terms of resources might be needed, and that can help you inform a funding application, for example, to demonstrate that you've considered these areas of inclusivity and incorporated them into your study. It comes with a toolkit of resources you can see on the right hand side, so a whole load of links, for example, to designing inclusive information. There's a library of completed frameworks so you can see some examples, and at the bottom there, that's an easy read guide to using this framework, so that when you're using public involvement contributors to help you design a study, you can actually use that easy read guide to discuss with them what this framework is and how you're proposing to use it when designing your study. Next slide. We've come up with some recommendations for using the framework. So importantly, this is part of a collaborative process. There shouldn't just be one person's responsibility. Public involvement that is inclusive in itself, of course, is essential throughout. We think it's useful for all populations who experience impaired capacity. It was co-designed with researchers across those groups, including palliative care. It's particularly thinking about clinical trials, but appropriate for all types of research. And as I say, using it at the earliest opportunity, building that into your funding application is really key, but also being clear about the legal frameworks. And that's where the training I mentioned earlier can help underpinning all of that. Next slide. And as part of that, we've been doing some additional work about thinking specifically about the consent process. So this is everything from providing information, supporting people to access and understand the information and make a decision, and then kind of recording what it is that they wish in terms of taking part in the study or not. And this is work that we've done where we've drawn on the literature around enhanced consent processes that we might see, for example, in clinical practice, and how we can draw on those when we're designing consent processes for clinical trials, but other types of research as well. And we've come up with some key recommendations, some domains that you need to think through, and that's what you can see on the screen there, not just the format, but the design, the support, the environment, the language, for example. We're going to be launching those recommendations at an upcoming webinar. You can see a link on the screen there, so you're very welcome to come along and join that, and you'll have access to the recommendations after that point. Next slide. And then we've also been doing some work around thinking about the challenges of acting, usually as a family member, and being involved in decisions about research on behalf of someone who's not able to express their own wishes about being included in a study or not. And we heard from Caroline what some of those challenges might be. So we know from the study that I've done and from other literature as well, that family members often feel unprepared to make research decisions. They might not know what the person's wishes would be about being included in a study or not, and that can lead to emotional and decisional burden, and then being more likely to decline participation. And that might mean that the decisions made on behalf of the person might not reflect their wishes. And you can see a quote there on the slide about someone talking about that the father had never discussed it. So they're making a decision. They're not sure whether it's the right or wrong decision, and only kind of time will tell. Next slide, please. So that led on to some work to help support people acting as a proxy decision maker. We've developed this decision aid that forms a kind of structured support for families where they can think through about what's involved in a particular study, and importantly, whether the person they represent would or wouldn't want to take part in the study. And we're actually evaluating that, embedding that in a number of research studies to actually see if it is an effective sort of form of support or not. Next slide. And then that kind of led on to thinking, well, actually, when we think about how we support people to express their views about other areas of life, to plan ahead, why not include research into that? And that led on to the concept of advanced research planning that Caroline mentioned. And we think about this as being a voluntary process that involves thinking about, discussing and documenting people's preferences for taking part in research in the future. It could involve documenting that in what we might term an advanced research directive. It could include naming the person you want to be involved in decisions on your behalf. It might be tailored to a specific research project, and we might term that advanced consent, or more general views about taking part in research in the future. Next slide, please. And whilst this seems like a really kind of promising idea, there are some issues that we need to think through, not least that we might need to think about it as a continuum. So everything from just having a conversation right through to completing a document and through to actually expressing consent for a particular study. Next slide. And one example of what that might look like in a palliative care scenario, and this is drawn from a scoping review we're doing at the moment, we identified this study, is that where someone's admitted to a palliative care unit, they might be given information about the unit being a research active unit, and then where potential participants have been identified as eligible, they would then be approached and asked if they would be prepared to enter the study if, in this case, they were to develop the difficulty breathing that the trial was looking at, and they would give consent in advance of becoming eligible for the trial. And then if they subsequently did become eligible, they would then be randomised, and their families, of course, were involved throughout the whole process, but their consent would still stand during that process. Next slide, please. And what we know is that actually this might seem really promising. Certainly when you talk to people, this seems a really great idea, but of course some questions remain. That actually if we introduce research into things like power of attorney or advanced care planning conversations, might it lead to misunderstanding, that kind of therapeutic misconception, the difference between research and clinical care, for example? Could people really know enough information ahead of time for it to be consent? Might there be lots of practical questions? We know about the uptake challenges around advanced care planning, for example. Might research be even more kind of distant from people's views and experiences? And where we have people who've expressed views ahead of time, how would we interpret those? Next slide. So that led to some study exploring the feasibility in the UK. We did a survey, followed up with interviews, found really high levels of support, but identified lots of kind of barriers and facilitators that we need to work through as part of the ongoing work. Next slide. But what people did identify as the kind of opportunities for engaging with discussions about future research might come up. So we might think about when people are putting power of attorney in place, advanced care planning discussions, is there the opportunity to say, have you thought about research? What would your views be about taking part in research should you develop issues around capacity in the future? Next slide. And so to kind of wrap all this up, and it'll lead us into the questions in a few minutes. We know that there are lots of these kind of ethical and legal challenges. We heard from Caroline about what that looks like from a palliative care perspective, but they span all populations where there might be challenges around capacity and consent. We're doing lots of work in this space across the kind of whole research community, thinking about more inclusive research, and that includes designing resources that you've already heard a little bit about that can actually help develop the skills and the knowledge to include people receiving palliative care who might have impaired capacity consent. That includes how we might need to support families, and importantly how we might encourage people to have conversations about their research preferences. And all this work is then going to be starting a big project next year where we look at actually the implementation of the legal frameworks and whether there might be areas for revising some of those to make them fit for the purpose when we think about changing populations and capacity over time. Next slide. So just to quickly acknowledge the funding support that we've received, both Caroline and myself, and also to highlight our contact details for more information. And as Caroline has mentioned, the opportunities to be involved in the network going forward. Thank you.
Excellent. Thank you very much indeed. What a fascinating group of presentations and lots of really important information. I'd encourage people, if you're on the call, to feel free to turn your cameras on. We've got some wonderful questions, but first of all, just to check, Caroline, is there anything else that you've not said that you wanted to say as a group?
I don't think so, no.
Was very comprehensive. So looking at the Q&As, and the panel can probably see them as well, there's a really interesting question Oh, sorry that you can't have functionality. I don't know if Michelle or colleagues on the call can turn it on, but I apologize if you can't.
I can see it.
Yeah. So I meant for participants to turn their camera on. I saw a quick message in the chat that it's not working. So sorry for that. Teams is a bit temperamental when it upgrades, isn't it? So first of all, a wonderful comment from George Konohan about whether the panel has thoughts about low risk research. So, you know, is this the place to start for novice researchers and research students? He's thinking of observing practice. I'd be very interested in your views, because I guess there's a number of ways of looking at it, I suppose. So I'd be very interested if one of you wanted to reflect on that, perhaps Vicky or Caroline.
Shall I go first? It's a really good question, isn't it? And I guess there are two ways of thinking about this. So first of all, low risk research, could mean that it's not interventional in that kind of manner. So we're thinking about perhaps qualitative research. You mentioned about observations in practice, and then it's whether it meets the threshold of research or not, because of course you might undertake observations as part of a learning process, perhaps audit and those kind of approaches, so it doesn't reach the threshold of research and so doesn't come under research governance. There might be opportunities there as well. But I think if you're working with these sorts of communities, involving them in research shouldn't be as onerous as perhaps we've given the impression today, because you would be very used to the kind of ethical principles that underpin this practice. The ethical review process, again, there's lots of tools and resources there, so certainly planning ahead for that. It might well be more achievable than it might seem, but it does take time and it does take some skill in navigating that process. So certainly drawing on more experienced researchers around you will really help you guide whether that is the route that you want to go down or not. And proportionality is a really key word in research at the moment. So I guess it's thinking about a proportionate approach to all of this. And certainly through the ethical approval process, proportionality is something that's coming through much more. So again, it's drawing on whether there are proportionate processes you can put in place to make it seem more manageable without kind of shortcutting any of the important ethical and legal considerations too.
Yeah, it's worth picking up on that. It's an interesting one. When I was looking at the portfolio, the studies, and also then thinking about some of the conversations we had around it, I suppose the challenge is that what some people were saying was that I'd only, critical care, I think, is probably a good example of this. Perhaps the only reason why someone would want to be involved in research at a very kind of acute or challenging part of their life is if it's a sort of a big ticket question. I'm not saying that's the case for everybody. And I think what's quite striking is that even in paediatric palliative care, there are some, what some people might consider quite high risk interventions that are being studied, but somehow researchers have been able to navigate the challenges to deliver those and recruit successfully to those trials. But there's something about, I don't know, adult palliative care where we're a bit more reserved about it, or the challenges feel a bit more difficult to overcome. So I think you're right in terms of developing those skills and expertise and a body of people who can do the research. It's important that we do studies that are smaller and that people can gain confidence to then build into bigger intervention studies. But equally, I don't think it's about saying, we shouldn't do those big ticket, questions in palliative care because the population is can't be exposed to any sense of risk, because actually part of, I suppose, thinking about people's autonomy in this is people may choose then to take on intervention studies that that essentially that's their choice to do that. But I would say that one of the things that came out quite clearly from our workshop was that potentially routine data, but as Vicky says, possibly also with observational studies, thinking about, if we can answer some of these questions without involving people, not only is that probably more ethical justifiable, but it's also a lot cheaper, it's quicker. And I know that King's have done a lot of work around this, for example. So I think there is a big piece of work there as well.
Thank you very much, Caroline. And George, I can see you're nodding, so that's wonderful. If I could share my reflection as well, is that just briefly, I think over the years, I've learned that research is always harder than you think. And even though you think it might be an easy study to do something crops up that you hadn't thought of. And my best advice really is to try and get in touch with people and get support and work with people who are doing things. And often another way to go, in addition to the way you've suggested, is actually to find some people who are doing a bigger project and say, can I do this element of it? Because actually then you get exposure to sometimes the very best methods. And my colleagues, and when I've done that, I've always found that fruitful, because I've learned something new and I've not felt quite so isolated. Because the other thing is that doing research very much on your own as a new student or not getting much help can be very isolating. And then you can end up feeling really disappointed because you've just done your piece of work, and 2 weeks before you're ready to write it up, you read a publication of somebody who's done exactly what you were planning to do, and they've sort of swept the ground from under your feet. And of course, there's so much that needs answering. So that would be my tuppence worth if I'm allowed to share them. But George, good luck with everything. I don't know if you want to come back on that, and then I'm going to turn to the question from Sarah Yardley. Is there anything you want to say, George, on that?
No, thanks very much. That's interesting and helpful. Yeah, I guess I'm still working on methods of involvement and trying to work out like what is it an appropriate method for an appropriate risk. There's a lot of kind of balancing and matching. But yeah. Interesting. Yeah. Thank you.
Yeah. Thank you. Now, there's also a very...
Irene, can I come in for a second?
Sure, Kathy, go ahead.
So I think it's very difficult to create a research culture in a place where that culture isn't already. And so from our perspective, actually, audit and service evaluation are also great entry points into doing this kind of work. But what I actually wanted to specifically say is that a conversation I had with a hospital charity a number of months ago, they were struggling to find how to spend their money. And I don't think this is a particularly unusual thing. So small amounts of funding, ask hospital charities. And I'm sure many of you will have had bits of funding from that. But for small projects, the odd 5 or 10K, ask your charity.
Excellent point. Thank you, Kathy. Right, I'm going to get in the next question, which is a very important one from Sarah Yardley now, which is about a little bit more about the structural barriers of including people in research, such as the protectionism that might exist, including from universities or NHS R&D or REC, research ethics committees, and the sort of issue of potential reputational risk over inclusion. So I'll let Sarah come back on that in a minute, but if she wishes to, but I don't know if anyone would like to just pick up that question from the panel.
I'm very happy to go with that one.
Yeah,
I say very
brilliant.
happy, obviously.
Thank you.
It's a difficult question, that one. I mean, I think one of the things is you're right, the system is very risk averse. We are aware of that. Patient safety obviously has to come first, but some people will draw quite a hard line on that patient safety. And the legal thing, obviously, here in this setting is a very clear barrier. I would say that one of the things that isn't always clear, and obviously I don't know you, I don't know your research, I don't know this is not my working environment. I'm a cancer researcher by background, so but it is not always clear what the overall impact is to balance against that risk. So if that's not really visible to the organisation, what will actually happen as a result? What will change the result? What will it get better? That's the point, isn't it? That's why we do the research in the first place, is to make something better. If that's not really apparent on an individual project level, then that risk aversion is unlikely to shift. We are keeping an eye on things like this nationally, but it's really useful for me having these conversations as well. If you want to follow this up and give me a bit more detail in the background, I would be very happy to have an ongoing chat. But I think there is also at the research community, you are a small research community in this space, and there are a relatively small number of experts at the top. So it's rely on your experts as far as you can, but that does put quite a lot of pressure on your experts as well. But on a national level, as I say, we are aware of risk. One of the things that we were trying to do just before we were told NHS England was being abolished, was make research more visible to NHS England boards. Sorry, I should not make the jokes about it all the time. At least that one was fairly blank, but rely on the black humour quite a lot these days. I'm sure many of you do. But we're trying to make research more visible, not just in quantitative terms, but in qualitative terms at provider and ICB board level, because it's when they have that sort of the qualitative, the understanding of this is a case study of a piece of work that we've done in our patch, that people are involved in, there's real human life in it. That's what boards are actually interested in. So NHS England has now decreed that providers and ICBs have to look at research. They have to have a board level discussion about research twice a year, which is a big step forwards. We are trying to mould what that discussion should look like. At board level, boards often enjoy their research discussions because it's like a step away from the difficulty of like financial management or risk management or whatever, reputation management. So they enjoy the conversations, provide the content for those conversations, make your things more visible.
Kathy, that's a wonderful point. I can see, Sarah, you've got your camera on. So do you want to just come in with any kind of reflections? And you've got an invitation to follow up there with Kathy.
Yeah, thanks, Kathy. Thanks, Irene. And yeah, a further conversation would be great, Kathy. I'll drop my email to you shortly. I mean, this is born of frustration. I find it as I'm a clinical academic, I'm a palliative medicine consultant. It seems ironic that when we are being a recruiting centre for a drug trial, we get less questions from the ethics committee than when we want to use lived experience and expertise to improve people's sense of care. So I think that's one thing which I just find hugely frustrating. But I think also one of the things that comes up a lot is we are trying to very much implement in our work having public co-investigators, and we've had studies that have gone to ethics committees and to the university where they've said you have to consent every time your co-investigator is going to do something because they're a member of the public. So they want to treat them as a research participant. And I'm like, no, they're part of our team. And it gets even more complicated in action research, where actually they're both of these things. And I feel that sometimes you get into this sort of top trumps type scenario where you're saying, well, my people who are public members of the public say this, and they're saying, oh, but our ethics committee person thinks this, and that's just not helpful. And I also I work not just in palliative care, but for people with significant mental illness who need palliative care, and they are all, you know, in my groups really angry, saying who are these people who are saying we can't choose for ourselves regardless of whether we have capacity or not. So I'm trying to negotiate all of that, and I often feel that the institutional answer is actually we're happier with the double-blind randomized controlled pharmaceutical trial because it's got fixed rules that we can all say tick or cross, and then we know where we are. And it's actually the openness and the co-productionness that you're trying to do that we just don't feel we can kind of endorse. So anyway, that's where I'm coming from.
Vicky, I wonder if
Sarah,
you want to come in on that,
yeah.
given another plug for your wonderfully titled paper, The Only Way is Ethics, about this very issue.
Yeah, just say I
Caroline,
would
thank you for
recognise
that.
a lot of those rec challenges. So yeah.
Yeah. Thank you very much for that. And actually, if you feel free to put that paper link in the chat, Sarah, because this forum is about sharing expertise. Very sadly, we're just out of time, I'm afraid. Mev, can you just quickly show the last two slides to close us while I thank the speakers for their amazing and wonderful presentations. Very informative. I learned a great deal. So we're planning the next webinar. So it's a great opportunity for people to put comments in. And then finally, and the link is in the chat, if you just please tell us what you thought and also send any comments or suggestions for future webinars. But Caroline, I'll turn to you and just say, is there any last word you want to say? And I'm going to say thank you to the three of you and those who've asked questions and those who participated to what was a really excellent presentation.
No, thanks, Irene. Thank you, everybody, for your participation. Yeah, do please all be in touch to keep the conversation going.
Thank you all for the great work you're doing. It's such an important topic. It really is. So thank you.